now?
Yeah, go ahead.
Okay, so I'm very glad to see so many of you all come here for my second lecture, that is Placenta Previa. Okay, so when they go low, you go high. Just for those who were not with us for my last lecture, if you all have any doubts or queries during the course of the lecture, you all please feel free to type it in the chat box below, and I'm going to try and address as many of them as possible at the end of the lecture. Okay. So let's start Placenta Previa. Now the term Placenta Previa, so the Latin term previa literally means going before. So as you can see, this baby very well rested on the placenta. The placenta goes before the presenting part in these pregnancies. Now the incidence of Placenta Previa is rising, mostly because of the rising incidence of cesarean sections. Okay, so the current incidence is 1 in 200 pregnancies. Okay, now what is Placenta Previa? It is the placental insertion wholly or partially in the lower uterine segment. Okay, now here I'm sure all of you all know the definition, but here I would like to highlight what exactly do we mean when we say lower uterine segment. So please take a look at the first picture in this grid figures. So here we can see this is the external os. This is a uterus with a very early gestation. So here we can see the external os. This is the internal os. And as we all know, between the external os and internal os, we have the cervical canal. So the internal os is called histological internal os. There is another internal os, this part, which is called the anatomical internal os. The part between the anatomical internal os and the histological internal os, we all know this, it's called the uterine isthmus. Okay, above this is the body of the uterus or the corpus, and on top will be the fundus of the uterus. Okay. The significance of uterine isthmus is that as pregnancy advances, as the gestation advances, this uterine isthmus gives rise, take a look at this figure, this uterine isthmus gives rise to the lower uterine segment. Okay, so it gets incorporated into the uterus to accommodate the gestation, the baby, and gives rise to the lower uterine segment. So remember, lower uterine segment is formed from the uterine isthmus. Okay, clinical relevance of the lower uterine segment is that if you take a look at this figure, there is no uterine musculature surrounding it. This is the cause of high incidence of postpartum hemorrhage in patients with placenta previa. This is because the lower uterine segment does not retract as well as the upper uterine segment after delivery of the afterbirths. Okay. Okay, now what are the types of placenta previa or the degrees of placenta previa? Type 1 is a low-lying placenta. Okay, so there are two figures here. This shows you the placement of the placenta in the uterus, while this figure down shows you the lower uterine segment with the internal os on an end-on view. Okay, so in type 1, the placenta is just lying in the lower uterine segment but not reaching up to the internal os. Take a look at type 2. This is also called a marginal placenta previa, in which the uterus is lying in the lower uterine segment and just reaching up to the internal os, but not covering it. Whereas in type 3, the placenta is partially covering the internal os, not completely. And in type 4, which is called the complete placenta previa, the placenta is entirely covering the internal os. So this type 4 is also called total placenta previa or a central placenta previa. Type 1, 2 and 3 are further divided into type A, which is anterior placenta previa when the placenta lies anterior to the uterus, and type B, which is a posterior placenta previa. So the more dangerous in this is a posterior placenta previa. We'll take a look at why soon. So for ease of classification, milder degrees of placenta previa are type 1 and type 2 anterior placentas. Major degrees are type 2 posterior, type 3 and type 4. So why is this posterior placenta so dangerous? For that, we need to understand what is Stallworthy sign. This sign is for academic purposes, of course, but I'm going to explain to you this sign just to impress upon you why a posterior placenta previa can be dangerous. Okay, so Stallworthy described this sign in 1951. It is the slowing of the fetal heart rate on pressing the fetal head down into the pelvis and its prompt recovery on releasing. Okay, so what happens in a case of posterior placenta previa? When you try to push the head down into the pelvis, the presenting part, that is the head, it compresses this posterior placenta. Now, this posterior placental compression interferes with the fetal blood supply, causing fetal bradycardia. Okay, but this sign is quite fallacious. Why? Because it is not specific only to posterior placenta previa. All of you will agree that even in a normal pregnancy with a normally situated placenta, if you try to push the fetal head down into the pelvis or any kind of pressure, even during the course of labor on the fetal head, will give rise to fetal bradycardia because of vagal stimulation. Okay, so this is why type 2B is called a dangerous placenta previa. It is a posterior marginal placenta previa. Okay, so there is a new classification now. Can you please switch off your mics? Can all the participants? May I please request you all to switch off your mics? Okay, thank you. Okay, so there's a new classification for placenta previas given by the Royal College of Obstetrics and Gynecology. In this, they have divided this entity only into two groups. One is a low-lying placenta, in which the placental distance from the internal os is within 2 centimeters. Okay, so these placenta do not cover the internal os. And the second group is placenta previa, in which there are two entities. One, total placenta previa, in which the placenta is totally covering the internal os, and partial placenta previa, in which the placenta is partially covering the internal os. So I would request all of you to please go through the RCOG Green Top Guidelines number 27A. It has been modified in 2018, and it gives a brief overview of management as well as entities of antepartum hemorrhage such as placental abruption and placenta previa. So please go through these guidelines. It would be of help to you. Okay. Coming to the risk factors, maternal age, parity, multiple gestation. So all of us know that in cases of multiple gestation, the size of the placenta is larger as compared to singleton pregnancy. So this is why there is increased chances of this placenta to encroach upon the lower uterine segment, giving rise to placenta previa. Okay, previous abortions and curettage. This also causes an aberrant decidual vascularization, giving rise to increased chances of placenta previa. Next, cigarette smoking, cocaine abuse. Again, this leads to hypoxemia, giving rise to a compensatory placental hypertrophy. Again, in this case, the placenta is enlarged and therefore higher chances of it encroaching upon the lower uterine segment. Then increased maternal serum alpha fetoprotein. Now, this, just like in case with placental abruption, acts as a predictor of placenta previa. Okay. Assisted reproductive technologies, this again increases chances of placenta previa. In today's time and age, with increasing pregnancies out of assisted reproduction techniques, there is increased incidence of placenta previa. Previous history of placenta previa, this is also very important because the recurrence rate of placenta previa is 2.4%. So whenever you all are taking history of your patients, please make sure that you'll go through her previous delivery notes, her previous operative notes, what was the indication for the cesarean section. All her previous history is as important as her current history. Okay, so this will better help you in managing this particular patient, because you'll always have a high index of suspicion, which is very important. Okay, and last factor is a previous uterine scar, especially cesarean section. Okay, now I'm going to discuss with you all a very interesting terminology, which is called as placental migration. I'm sure all of you all have had patients at around 18 to 20 weeks of gestation come to you with an anomaly scan suggestive of a low-lying placenta or a placenta previa. But I'm sure you must have seen that in most of these patients, by the time they reach term gestation, the placenta has reached a normal implantation in the upper uterine segment. This patient may even have a normal vaginal delivery. Okay, so this apparent movement of the placenta away from the internal os is what is called placental migration. Okay, remember everyone, it's an apparent movement. The placenta doesn't actually migrate. So what causes this phenomenon? So first, trophotropism. So this is the first theory where they state that a greater blood flow to the upper uterine segment causes preferential growth of the placenta towards the fundus. Okay. And second theory is that a differential growth of the upper and lower uterine segments. We know that the lower uterine segment develops later on in pregnancy. That is in the beginning, towards the beginning of the third trimester. So this causes the placenta to be pushed upwards towards the fundus. So remember, placental migration, it is an apparent movement of the placenta away from the internal os. So do all placentae migrate? That's my next question to you. So all placentae do not migrate. What factors make placental migration less likely? Or in which cases will a placenta previa diagnosed at 20 weeks remain a placenta previa even at term? Okay, so these cases are in cases of previous cesarean deliveries, higher degrees of placenta previa, that is either a partial or a total placenta previa, and posterior placenta previa. Okay, so in the other types, that is in low-lying placentae, around 90 to 97% of low-lying placentae diagnosed at 16 to 20 weeks will normally be situated by term gestation. Okay, to make you understand this, this is an adaptation from Williams Obstetrics, the 25th edition. This graph on the x-axis shows you gestational age, and on the y-axis we have persistent placenta previa at delivery. So if you can take a look at the green curve. Okay, now the green curve, this is the green curve. It denotes placental distance from the internal os 1 to 5 millimeters and no previous history of cesarean delivery. CD is cesarean delivery. Okay, if you take a look at these patients, by 28 weeks of gestation, the percentage of people in whom there is a persistent placenta previa is only 5%. Okay, compare this with the red curve. Now, red curve denotes all patients of placenta previa along with a previous history of cesarean delivery. So in these patients at 28 weeks of gestation, almost 80% of them will have a persistent placenta previa. So the risk factors, that is previous cesarean delivery and higher degrees of placenta previa, will cause persistence of this placenta previa even at term gestation. So how frequently should you do sonographies for these patients? Should you do them every 3 weeks, every 4 weeks? Okay, so there are specific guidelines and recommendations for this. This I have adapted from, again, RCOG recommendations, Green Top Guideline 27A. The mid-pregnancy routine fetal anomaly scan which you perform should always include a placental localization. On this scan, if you find that there is a low-lying placenta or a placenta previa, the next follow-up sonography examination should be done at 32 weeks of gestation. Okay. At 32 weeks also, if there is a persistent low-lying placenta or a placenta previa, the next scan should be done at 36 weeks. And at 36 weeks, this scan will show you the exact placental location and will also help you in planning the mode of delivery. So to make things a little simpler, I have made this timeline for you, which will show you better what I'm trying to say. 18 to 20 weeks of gestation, anomaly scan plus placental localization. If this scan diagnoses a low-lying placenta or placenta previa, then repeat the transvaginal ultrasound at 32 weeks. 32 weeks also you find that the patient has a persistent low-lying placenta or a placenta previa. Patient is asymptomatic, no bleeding. Repeat the scan at 36 weeks. Now at 36 weeks, if you find that there is a placenta previa or a low-lying placenta, then you need to plan the delivery. Okay. Now, before management, coming of course to the diagnosis, that is the clinical presentation of the patient. All of us know the most important clinical presentation in patients of placenta previa, that is vaginal bleeding. However, this vaginal bleeding has certain very specific characteristics. Now, each and every one of these characteristics which I'm going to be reading out is very important for the differential diagnosis of placenta previa. So one, it is a painless bleeding. Okay, compare it with the bleeding which is seen in placental abruption. In abruption, there will almost always, it will be associated with pain and abdomen, especially in concealed hemorrhage. Okay, here the bleeding is causeless, unprovoked. There is no history of previous abdominal trauma. Okay, it is an unprovoked painless vaginal bleeding. Okay, and the bleeding more often than not is recurrent. Okay, second point, the uterus is relaxed unless the patient is in labor. Compare this with other causes of vaginal bleeding such as abruption, where the uterus is tonically contracted, okay, in a tachysystole, and even in uterine rupture, the uterus, the patient will complain about abdominal pain. Okay. Third, malpresentations are more common. Okay, why? Because the lower uterine segment is all occupied with the placenta. So there is no place for the large fetal head sometimes to accommodate itself in the lower uterine segment, which is why placenta previa more often is associated with breech presentations and transverse lie. So it is very important to diagnose these before you plan your mode of delivery. Okay. Now, sentinel bleed, very commonly seen in placenta previa or low-lying placenta. As I said, it is a painless bleeding, occurs without warning, generally at the end of the second trimester or beginning of the third trimester. Why? Because this is the time where the lower uterine segment starts developing and there is a remodeling of the uterus causing placental shearing and separation. So as the placenta shears off its decidual surface, there is bleeding. Now, thankfully, this bleeding is rarely fatal. It is not a profuse bleeding, okay, and it generally stops on its own, okay, but it is a recurrent bleeding. Okay, so this is called a sentinel bleed, typically seen in placenta previa. Diagnostic modality, of course, is ultrasonography. Now, a very important point I want to highlight here is that clinicians should be aware that transvaginal sonography for the diagnosis of placenta previa is superior to transabdominal and transperineal approaches and is safe even when there is bleeding. Okay, so you can do a transvaginal sonography. It is more sensitive than a transabdominal and transperineal sonography. Okay, transabdominal sonography, it's a little difficult, especially in obese patients. The visualization is not very clear. Secondly, when the bladder is very full, as required in a transabdominal scan, there could be a false elongation of the cervix, as well as a low-lying placenta gets compressed by the bladder, and therefore you can falsely misinterpret it as a placenta previa or higher degrees of placenta previa. Okay, so here is an image of a B-mode ultrasound showing the fetal head and the placenta just below it. Okay, so the placenta goes before the presenting part and it is almost covering the internal os. Okay, so you could say that this is a partial placenta previa. Okay, along with a cervix over here. Okay, so with the advent of sonography, this has become the diagnostic modality of choice. However, I'm going to explain to you something called as a double setup examination. This is very rarely necessary, but mostly I'm explaining this for academic purposes. Generally, this is not done. This is a kind of examination which is done for diagnosis of placenta previa only when USG facilities are not available. Patient has come to you with bleeding per vaginum and you do not know, she has no recent scan showing the localization of the placenta. So in this situation only, you can do this examination. Now, what is this examination? It is a cervical digital examination done with the patient in the operating theatre. Very important. Also with preparation for immediate cesarean section if required. Okay, so each and every word of this is important. This examination should be done only in a fully functional operating theatre with all preparations in place for an emergency cesarean section. Why? Because this digital examination can lead to torrential hemorrhage Okay, and you might have to perform an emergency cesarean section in case that happens. So keep an anesthetist arranged, keep blood and blood products in place. However, as I said, sonography has been widely available, and if not, then at least patients generally are registered now and have recent scans. So this kind of examination is rarely required, but you should know about it. Coming to the management, now management depends on three important aspects. One is gestational age of the patient, whether the patient is in labor or not, and third is the severity of her bleeding. Okay, so for convenience, we're going to distribute the patients into two. One group who present to you with bleeding PV, and the second group who are asymptomatic, that is without any bleeding. Okay, so patients who present with bleeding per vaginum can be managed expectantly, that is a conservative management, or they can be delivered. So how do you decide that? So first class of patients presenting with bleeding per vaginum. Now, as I had highlighted even in my previous lecture, all the preliminary measures are very important. First and foremost, you will call for help. Even if you are the most efficient doctor, you will always require help. Okay, so assess the general conditions, which includes the pulse, blood pressure, saturation. Assess the amount of blood loss. Okay, so check visually at least how much of her clothes are soaked. Ask for history of passage of clots. Okay, so at least you can get a brief idea as to how much blood loss she has suffered. A quick history, if there was any pain associated with the bleeding, whether there was history of decreased fetal movements or any previous such episodes with minor hemorrhage which stopped on its own. Okay, so this again points towards placenta previa. Secure an IV line, do your routine investigations, keep blood grouping and cross-matching ready. Bladder catheterization, especially in cases of massive hemorrhage. Examination, upper abdominal examination to rule out abruption, check for labor contractions, auscultate the fetal heart. If you have, wherever you're working, if you have the facility for a portable USG or a bedside USG, please do a USG scan to find out the location of the placenta. And most important, avoid a per vaginum examination. In cases of placenta previa, I cannot tell you how important this is. I'm going to share with you an experience during my residency when a patient around 36 weeks of gestation, complete placenta previa, an inadvertent per vaginum examination was performed upon her, and the patient had torrential bleeding, massive hemorrhage. She had to be rushed to the operation theater, and an emergency cesarean section was performed. The mother and baby both were fine in the end, of course, but she required a number of blood and blood products. She went into, she had maternal anemia thereafter. She had lactation failure. She had to be given higher antibiotics to prevent sepsis. So all this can easily be avoided. If you're a little careful, look at her papers, look at her scan, and then, only then, a patient with vaginal bleeding, avoid PV examination until and unless you have ruled out a placenta previa. So thankfully, I was in a tertiary care center, but what if this mistake had happened in a periphery center or a low resource center? Okay, so you have to be very careful. So please keep this in mind. Avoid a per vaginum examination in patients of placenta previa. Okay, so what is expectant management? That is conservative management. So McAfee has described this kind of management in patients who have come to you with bleeding PV, but only in the following situations. That is in prematurity, that is gestational age is less than 34 weeks. Minor hemorrhage, small area of placenta has been detached and the bleeding is not too much. It is just a minor hemorrhage. Fetal and maternal condition is stable. Okay, so when all these factors are satisfied, only then can you give her a conservative management. Because the aim of this management is to prolong pregnancy at least till fetal maturity and if possible till term. Fetus will develop compensatory mechanisms to make up for the blood lost provided the bleeding is not severe. Okay, so what comprises expectant management? You will admit the patient in the hospital, but what next? What all do you watch for in the patient? Complete bed rest and restriction of activity. Maternal monitoring, very important. Her pulse, blood pressure, bleeding. Give her sterile vulval pads. Find out the amount of blood she's losing. Fetal monitoring, again, very important. Send her routine blood investigations, correct any maternal anemia if present, because you never know when she's going to have another episode of bleeding. So you might as well have her blood reserves in store. Administration of steroids in all premature patients. Tocolysis should be used briefly for steroids to act. Okay, so if delivery is indicated based on maternal or fetal outcome, tocolysis should not be used in an attempt to prolong gestation. Very important. Tocolysis can be used only for that brief period of time, so that you give the patient enough time for the steroids to act. Okay, not to prolong gestation, because the patient is not in labor. Okay. Prophylaxis against venous thromboembolism. Now, if you have the patient admitted in your hospital for more than or equal to 3 days, you, depending upon other risk factors in her, maybe a previous history of thrombophilia or any other previous history of cerebrovascular accidents, you need to give prophylaxis against DVT, deep vein thrombosis. So these can be given in the, just 1 minute. Yeah. So this can be done in the form of elastic graded stockings or unfractionated heparin. So now guidelines suggest that instead of giving a low molecular weight heparin, it would be better to give an unfractionated heparin. Why? Because unfractionated heparin has a shorter time interval and it can be easily reversed in case the patient has another episode of bleeding and she has to be taken for an emergency cesarean section. So preferable to use unfractionated heparin for prophylaxis. Again, in-hospital management is very important, but after 48 hours of the patient having no bleeding per vaginum, patient is stable, the fetus is fine, you can discharge the patient provided you give her standing instructions as to when she should report back. Okay, so now I think this is a very important slide. All of you must pay attention to this. What to counsel the patient when you're discharging her, a patient of placenta previa? That she should attend the hospital immediately if any bleeding, including spotting, any contractions or abdominal pain takes place. Patient and relatives should be counseled about the risks of preterm delivery, obstetric hemorrhage, and blood transfusion. And the last point, most important point, patient should have ready access to your hospital. Okay, this includes not only transportation but also someone to accompany her. When she's at home, there should always be an attendee with her who, in cases of emergency, can bring her to the hospital. If this is not possible, if there is no transportation or she lives too far away or there is no person to accompany her, then it will be better if you keep her admitted in your hospital till delivery, because you never know when the next bout of bleeding is going to occur. So coming to contraindications to expectant management, any massive hemorrhage, deliver the patient. Profuse bleeding, recurrent bleeding, if she's preterm, give her a course of steroids, deliver the patient. Bleeding in term patients, no point in waiting, she's already at term. Unstable maternal and fetal conditions, obviously you will deliver the patient. This brings us to asymptomatic patients who do not present with any bleeding, but they have placenta previa. So here in this slide, I would like you to take a look at the middle flow chart. Okay, so the first box showing you a diagnosis of placenta previa, low-lying placenta on 18 to 20 weeks of gestation ultrasound scan. We did a 32 weeks follow-up ultrasound, which shows that low-lying placenta or placenta previa still persists. Okay, so following that, at 36 weeks, transvaginal ultrasound is repeated. Now, in this scan, if you find that there is no placenta previa or no low-lying placenta, she goes to again low-risk routine prenatal care. However, if there is any placenta previa, either partial placenta previa or total placenta previa, she will go straight for a scheduled cesarean delivery at 36 to 38 weeks of gestation. Okay, so the higher degrees of placenta previa, always an elective cesarean delivery. Whereas low-lying placenta patients, you have to see, to decide the plan of delivery in patients with low-lying placenta, you need to measure the distance of the placental edge from the internal os. And this, if you're doing your own scans, well and good. Otherwise, you will have to request the sonologist to give you the distance of the placental edge from the internal os. So now, if this distance is less than 1 centimeter, patient goes straight for an elective cesarean delivery at 36 to 38 weeks of gestation. If this distance is between 1.1 to 2 centimeters from the internal os, you can give this patient a trial of labor. Okay, Oppenheimer has given this classification depending upon the transvaginal ultrasound, distance of placental edge from the os, and the pregnancy outcome. Okay, so when do you do a cesarean? When do you opt for a normal vaginal delivery, or at least a trial of labor, depending upon the distance of the placental edge from the os? So when it is more than 2 centimeters from the os, a cesarean delivery is not indicated. You can give her a trial of labor. When it is 1.1 to 2 centimeters from the os, again, patient can be posted for vaginal delivery. She has a low risk of cesarean section as well as antepartum hemorrhage. However, when the placental edge is within 1 centimeter, that is 0 to 10 millimeters from the os, for all practical purposes, post her for a cesarean section. Okay, so she's at a high risk of antepartum hemorrhage as well as cesarean section. And of course, the last point, any overlapping of the os by the placenta, whether it is partial placenta previa or total placenta previa, always a cesarean section is indicated. Now, what are the precautions to be taken at delivery? First, the laparotomy incision in cesarean sections. In cases of a massive hemorrhage, where it is an acute emergency, okay, most surgeons advocate a vertical midline incision, and their point is that it provides for a rapid or a faster entry into the abdomen, plus a vertical incision will give you more space in case an obstetric hysterectomy is required. However, those surgeons who are more used to doing a fan and steel incision as routine in any other cesarean section have argued that they are more comfortable with the fan and steel incision, and their entry into the abdomen is faster with the fan and steel incision because they have been doing it regularly. So this again depends upon the surgeon's preference. The uterus incision is ideally a low uterine segment transverse hysterotomy incision. Some of them again have argued with an anterior placenta previa. In order to avoid cutting through the placenta, you can use a classical hysterotomy incision. But with the classical incision, the problem is that it has a very high incidence of postpartum hemorrhage as well as rupture in the next pregnancies. Okay, so where possible, use a low uterine segment transverse hysterotomy incision. In case of anterior placenta previa, how do you reach the baby? You can always find the placental edge. Okay, most often you can find the placental edge, go below the placental edge, perform an amniotomy and deliver the baby from under it. Okay, but sometimes that placental edge cannot be reached. Okay, for example, in cases of partial placenta previa with an anterior lying placenta, you will have to, in this situation, cut through the placenta in order to reach the baby. But remember, when you're cutting through the placenta, you have to immediately deliver the baby and immediately clamp the cord. Why? Because once you cut through the placenta, the bleeding which takes place is fetal blood. So unless you clamp the umbilical cord immediately, there is going to be fetal hemorrhage, fetal anemia, and fetal morbidity. Okay, so that was during a cesarean section. Now for a vaginal delivery, active management of the third stage of labor should be done. Why? Because all patients of placenta previa are at a very high risk of postpartum hemorrhage. Let's take a look at why. I've already shown you what a lower uterine segment is. It is not surrounded by myometrium. This is the lower uterine segment. Take a look at the figure below. Yeah, it is not surrounded by uterine myometrium. Therefore, a placenta which is implanted here, okay, once the placenta delivers, this passive segment has poor retractability. It does not contract, and therefore there is increased bleeding from the placental bed. So how do you stop or control this bleeding? What are the measures to prevent postpartum hemorrhage? So I'm going to briefly summarize it here. However, I will be discussing postpartum hemorrhage as a separate topic in one of my later lectures. But in case of placenta previa, first point, active management of third stage of labor if patient has undergone a vaginal delivery. Okay, so in this, you know, after delivery of the anterior shoulder of the baby, injection ergometrin to be given. Once the baby is delivered, uterine massage, uterotonics, oxytocin, controlled cord traction and delivery of the afterbirths. Okay, even during cesarean section, uterotonics should be given after delivery, oxytocin, ergometrin, prostaglandins. Once the placenta is delivered, sometimes you can see in a cesarean section that the placental bed still has a number of oozing points. So most often, application of pressure to these oozing points generally controls the hemorrhage. But sometimes when that does not happen, you can take sutures on the placental bed. Okay, so interrupted sutures using number 0 chromic catgut or polyglactin can be done. Another method, which is a conservative method of preventing postpartum hemorrhage, is uterovaginal packing and a balloon tamponade. So these are all the balloons or the kinds of catheters which can be used for prevention of postpartum hemorrhage. So you have the Buckley balloon, around 300 to 500 ml capacity, Sengstaken Blackamoor tube, Rush's balloon, condom catheter. Okay, so all of them, they cause a tamponade preventing bleeding from the placental bed. Okay, so of all of these, I would like to draw your attention to the condom catheter. Now, if you don't have any of these in your hospital, especially if you're working in a low resource setting, a condom catheter can work wonders. How to make this catheter, how to place this catheter in the uterus, what is the mechanism of action of this catheter, all of this I will be discussing in my lecture on postpartum hemorrhage. Okay. Other methods of controlling PPH, hemostatic compression sutures. Okay, so you can see the diagrams over here, the figures. Beeline sutures, chose multiple square sutures, or a combination of these can be used. Okay, so in this, there is the anterior and posterior uterine walls are compressed against each other. Okay, that prevents bleeding. Next step, systematic devascularization of the uterus. So that includes your uterine artery ligation, ligation of the utero-ovarian anastomosis, and internal iliac artery ligation. Okay, and last ditch resort, if nothing else works, you have to resort to a hysterectomy, especially in cases of morbidly adherent placenta, that is placenta accreta, increta, percreta. Okay, the higher chances of obstetric hysterectomy in these cases. So one point, important point to take home in this slide, keep blood and blood products ready during delivery of patients with placenta previa because they have a higher incidence of postpartum hemorrhage. Coming to maternal outcome and fetal outcome. Maternal outcome, massive hemorrhage, shock, maternal anemia, sepsis, increased morbidity, mortality. Okay. Fetal outcomes mostly due to preterm deliveries and prematurity, which includes asphyxia, respiratory distress syndromes, malpresentations and their complications, and increased morbidity and mortality. So that brings me to the end of this lecture. Just the last slide for take-home messages. Good clinical acumen is very important in these cases. Cesarean section should ideally be performed by an experienced surgeon. Early cord clamping if you have cut through an anterior placenta previa during a cesarean section in order to prevent fetal hemorrhage. Okay. Active management of the third stage of labor in vaginal deliveries. Be prepared to manage postpartum hemorrhage. Keep your blood products ready. Inform the blood bank. Coordinated teamwork is going to go a long way for optimizing the management of these patients. Not only the maternal, but also fetal outcome will be optimized. So, before I take on the questions, I'm just going to announce my next topic, which will be morbidly adherent placenta